Thank you very much for a very comprehensive and raising few questions that we would be able to discuss about the effects on families. I would like to invite Dr. Danny Horesh, a senior lecturer and the head of the Trauma and Stress Research Lab at Bar-Ilan University, Department of Psychology. He is also the head of the Child Clinical Psychology Track program at Bar-Ilan University. Dr. Horesh, as we said before, completed his PhD under the supervision of Professor Zehava Solomon, focusing on delayed onset of PTSD among Israeli war veterans. Following his doctoral studies, he received the Rothschild Scholarship and did his postdoctoral training at NYU Department of Psychiatry under the supervision of Professor Charlie Marmar. There he studied trauma among both military and civilian populations, including residents of urban low-income areas in the United States. Dr. Horesh still holds an adjunct faculty position at the NYU, where he has several research collaborations. Currently, Dr. Horesh and his team are conducting multiple research projects in the area of trauma and stress. These include studies of childbirth-related PTSD, that we will hear about it today, a large study of PTSD and trauma perception among individuals with autism, very interesting, and several projects examining secondary traumatization and trauma narratives. His team also conducts randomized clinical trials of mindfulness-based intervention for a variety of stress-related conditions. So we welcome David.
Good morning, everyone. First of all, it's a great honor to be here today, honoring Zehava and remembering all those years in the lab, these very precious years. Zehava has been, you have been a great mentor to me, you know that. And yesterday, me and Gadi were talking in the hall, and we were thinking that not only did we learn so much about science and research and life here in the lab, but we actually got married during our years, not me and Gadi, but each one of us separately. We got married during these years, and we had children, and we established our families, and I think for many of us this was a second home. And I think it's no coincidence that people who come to be your students, and I still see them here today, stay for very, very long years. It really isn't a coincidence. It's due to your inviting and generous and warm character. So thank you for these formative years. I will be talking about stillbirth and pregnancy loss and PTSD today. I have to say, as a disclaimer, this is a secondary traumatization symposium. This study is not a classic secondary traumatization study, but I think it has a lot of implications for secondary traumatization, as I will try to point out, and especially for family coping with trauma. So the contextual nature of the study, I hope, will be very apparent. What I will describe is a collaboration. It's a collaborative study that's been going on for several years between my lab at Bar-Ilan and the Hadassah Women's Department in Jerusalem. And I think since we're going to enter a quite difficult topic, an emotionally difficult topic, I will try to give you a few examples or a few testimonies from people who have gone through this experience. This is a very beautiful book, poetry book by an Israeli poet named Eran Bargil. It's called The Sorrow of Growing Pumpkins. The entire book is a metaphor about trying to raise this vegetable garden as a metaphor for trying to raise a child or giving birth to a child. I think you can see the very direct pain of the father this time, not the mother, which will connect to my talk. So I will not go into every single definition of pregnancy loss and stillbirth. I will try to say something maybe a bit more general that will kind of serve as a gateway into my talk. Mostly referring to this, I think, disputed categorization between early pregnancy losses and late pregnancy losses. We can use a gestational week or pregnancy week 22 as kind of a benchmark, which many medical institutions tend to hang on to divide between early pregnancy losses to late pregnancy losses and stillbirth. Stillbirth is mostly refers to pregnancy loss from week 22 of pregnancy and onwards. The definition slightly changed from country to country. That would be the average. It entails the birth of a dead, well, either fetus or baby, or anyone can choose their own personal subjective ideology. The present study will discuss late pregnancy losses and stillbirth as potentially traumatic events. And we are dealing with traumas and traumatic events, so the details are important, and the circumstances of losses can be highly varied. The loss can be caused from either fetal death or medical termination or numerous other medical complications. This means that it may entail a decision by both partners to end the pregnancy, or it can occur naturally. So the circumstances are multiple. It's not a very rare occasion, and I think I will try to say something about how rare a trauma is and how rare are the studies actually examining it. So I said that it's not a secondary traumatization study, but I think that if we're going to refer back to Zahava's metaphor of the stone and the water, then the circles or the cycles of adversity are very, very clear in this specific events. So these are just some of the cycles, but I think it's quite obvious that starting from the individual, we have a woman who gave birth in a very, very traumatic way. Usually, but not always, she may have a spouse. They're, of course, affected. And as Gadi showed, I think, no direction is unidirectional. We have bidirectional associations. They still live together, and their distress may affect one another. We obviously have, well, usually, at least in Israel, there may be current children or future children. So pre or post childbirth, how are they affected by the distress? And the most neglected population in terms of secondary traumatization is the medical staff. If you try to look how many studies of midwives have been conducted, in this specific circumstance you will find very few. And of course, if you look at doctors, you will find a bit more, and the hierarchy of trauma, which was something that I learned a lot from Zahava, the politics of trauma research. So a few shortcomings, or I think, you can say shortcomings of previous pregnancy loss and stillbirth research. Almost exclusively were they done in developed and Western English-speaking countries. I think the UK has turned into an empire in childbirth-related PTSD, and it's kind of paved the way for a lot of us. But when you look at developing countries and non-Western countries, you will find very, very few. In terms of outcome measures, a lot of the studies, most of the studies have focused on depression and complicated grief. I think there's something very intuitive about looking into grief and depression and dysphoric disorders in this context. PTSD has came to the forefront, I think, only in recent years in this respect, but really not enough studies, especially in the area of DSM-5 and what Gadi has talked about. And not surprisingly, the vast majority of studies have focused on the mother, and even and just asking about the dyad or couple's relationship in the context of pregnancy loss has been very scarce. And again, looking at Israel, unfortunately, I think we're such a trauma empire and a natural stress lab, but we certainly know a lot about the military context of trauma. What about the civilian, daily, day-to-day traumas? I think we know much less about them. And then, because of all these reasons, about 5 years ago, my team and I decided to conduct what is the first large-scale quantitative Israeli study of psychopathology following pregnancy loss. And when I'm saying the emphasis is on quantitative because there are great qualitative studies in Israel. The samples are naturally smaller. The methodologies are different. And we wanted to do something that is quantitative and is based on a larger sample. So the very general aims were first to assess the prevalence of psychopathology using validated measures of PTSD and depression among women who have experienced pregnancy loss, and to examine various predictors of psychopathology. The ones that have interested us the most were dyadic measures. That's why I think I'm in this symposium. What happens to the dyad that is in the shadow? This is not an individual trauma. It's mostly a spousal and familial trauma. What do we know about that? What measures predict psychopathology, resilience, and vulnerability? And also background variables, not only socio-demographic, but pregnancy-related variables, the circumstances of the loss, the circumstances of the pregnancy, when did it occur, how did it occur? Because we believe that in terms of prevention, that would be very important. So, the dear woman here is Malka Nukrian. She was my partner for this study, a very special woman. I think you can say she's a true champion or advocate of the pregnancy loss issue in Israel. She's been leading support groups in Hadassah for many years. She's also a midwife, and she kind of got the informal role of taking care of women who have gone through pregnancy loss at Hadassah Hospital, which is a huge hospital in Jerusalem with a highly varied population. And she was responsible for her amazing recruitment with also almost no refusals on part of the women. It's a very, very vulnerable population. Approaching them and getting them to actually participate could be very, very difficult if you don't have someone who really is from the inside and knows the emotional experience. So 103 Israeli women who experienced pregnancy loss after the first trimester, I'm going to say something about that. The vast majority of women in this study have gone through very late pregnancy losses. It's a very high-risk population. There were a few, maybe 6 to 8 women who experienced losses at week 17, 18, 19. We decided to include them post hoc. We did some analyses and we saw that actually in terms of outcomes and psychopathology, they were no different from women who experienced them very late. So it's a late pregnancy loss study, but we do have a few women there. I'm just saying this methodologically. I'm used to answering reviewers about this question. It's an important question. They were recruited through Hadassah and Karim Hospital's women's department. So the mean week of pregnancy where they lost the baby was almost 28. But actually, when you look at the sample, 42% were week 30 and above. About 35% were actually weeks 35 to 41. So it's a very, a priori, very high-risk population. Highly educated sample. Since it was Jerusalem, it allowed us for a nice distribution of religiosity, which turned to be very important for us. Most of them in a relationship, vast majority with children. We had quite a big spectrum of the mean time since the loss. We thought real hard about whether we want to restrict or have very, very strict exclusion and inclusion criteria in this regard, and then we decided that no, we want, as a first study, we want to do something exploratory and actually kind of open the space for a wide variety of recency effects. But still, almost half the sample was 6 months or less, so pretty fresh traumas for a large proportion of our sample. Almost 90% experienced stillbirth, and that's, of course, highly correlated with the fact that they were, the vast majority, experienced late pregnancy losses. And I think an interesting finding for us, which we haven't really touched yet, was the number of previous losses. So the average woman in our sample had already, this was already her third loss. And this has medical reasons, but, you know, talking about transmission or looking at a systemic approach to trauma, maybe there are also emotional or stress-related reasons. At least the gynecologists we consulted had no clear reason for this, other than the medical reason. So this was a self-report measure, cross-sectional design. We have more measures than are presented here, but these are the ones that I will discuss today. We administered the PCL-5 for PTSD, the Beck Depression Inventory for depression, the Dyadic Adjustment Scale, which is a scale that I kind of fell in love with, working with Zahava in many contexts, the Self-Disclosure Index, and the Post-Traumatic Growth Inventory. Okay. So, if I had to say only one thing and then leave, I would say something about the next slide, because I think that's the most important one, at least for me, and that's just the rates of psychopathology. For once, taking validated tools and looking at the breadth of this phenomena of PTSD in pregnancy loss in Israel. So here they are. We used several cutoffs of the PCL. The PCL is the most commonly used self-report measures of PTSD today. There is a debate about the adequate cutoff these days. When we started, I think we also had these conversations. We adopted the most conservative cutoff for civilian population, which was then 38. And adopting this cutoff, we found that 1/3 of our sample had full-blown PTSD. And I think it's kind of interesting to come after Gadi, who showed us the rates of people coming back from combat or from torture. And I think it's not that different if you look at that. So these are very, very alarming rates of a very, very daily civilian trauma. Ever since then, ISDSS and the National Center for PTSD have recommended actually using lower cutoffs for civilian populations. Right now, the formal recommendation of the National Center for PTSD is 33, so we tried that, and then we came to 42% of PTSD. So this, I think, should be very, very alarming to us. Where are we not looking, and why? And I'm sure, I won't do that, but I'm sure that if I ask anyone in here if he or she knows anyone who have gone through late pregnancy loss or stillbirth, there would be 100%, yeah, everyone will raise their hands, and we're talking about personal acquaintance. Again, when we we played with the criteria according to full DSM-5 criteria, which are very, very harsh. The rates came down. Not that they're not alarming, but they are still lower. And a very large portion of women who had subclinical PTSD, the vast majority of them, 33%, but out of them, about 80 to 90% were actually very, very, very close to the cutoff. So the true rates of distress, of PTSD-related distress, are much higher in this sample. Going to major depression, it should come as no surprise. So about the same. 30% of our sample had at least moderate depression, so moderate to severe major depression. And I think, Professor Nuria, you spoke yesterday about comorbidity, and I think it's for me, it has always been a major issue and a major point of interest, but here I found it again very, very alarming. So the comorbidity is very high, around 50% as you presented, but then we have this one group, one subgroup. The women who had severe depression, 100% of them had also full-blown PTSD. So that's, so we have a group. We have an identified group, a very vulnerable group, which we don't feel we know enough about. Who are these women? Can we identify them already at the women's department? How can we prevent? How can we screen? Because this would be a very important group to identify and treat. To get a feeling of that, this is something that one of our participants had said. Some of them were kind enough to talk to us and also to express themselves more freely. So a lot of guilt, a lot of shame, a lot of confusion, obviously. And when we think about PTSD in regards to pregnancy loss, we should think, well, we all know in this room that PTSD feeds off of sensory experiences. It feeds off the graphical, of the very unique characteristics of the event. And we should think about pregnancy loss, late pregnancy loss and stillbirth as giving birth. There are so many smells and sights and touch and medical staff is all around you. And there is a lot to remember. The senses have a lot to feed off from, sometimes in a very, very aching way. So looking at the predictors of psychopathology following pregnancy loss, we ran a few regressions separately for PTSD and for major depression. And this is the final model of the regression. We see that younger women who were, if we're looking for a profile, so women who were younger at the time of the loss, the younger mothers were the most vulnerable. The secular mothers, as opposed to the ultra-Orthodox mothers, and again in Jerusalem we had the entire spectrum, and we know a lot about the associations, the complex associations between religiosity and PTSD. And obviously, time since the loss and the week of loss, okay? So the more recent the loss and the more advanced the week of pregnancy, the more vulnerable the woman was. So here we have somewhat of a profile of a vulnerable woman. I have circled whether or not the woman currently has children to show you that it was in no way predicting PTSD or lack of PTSD, but it will pop up again somewhere in this study, and it will be interesting to see why then and not now. And when looking at depression, we have less predictors, but similar ones, mostly the time since the pregnancy loss and the week of pregnancy loss, and a marginally significant effect for religiosity. Previous pregnancy losses, no. And of course, this is only the final model of the regression. We had so many background predictors related to the circumstances of the loss, what happened in the room, how did the pregnancy go. We did not find effects there, okay, interestingly, and as opposed to some of the other studies. So this is what I just said. The circumstances of loss played no role. The week was. Again, we spoke within ourselves, and when we published, about the fact that there is something very unique. Again, another thing I learned in Zahava's lab was to treat time as a very complex entity. And I think pregnancy kind of allows us to look at each passing week as something that has a lot of psychological correlates. What happens to the woman's expectations? What happens to the expectations when pregnancy reaches week 30 or 35 or 41? And obviously we don't know that because we haven't asked about that, but we have very good reasons to believe that this is what time brought. It brought a lot of expectations, something very tangible about the emerging motherhood that is about to happen. And then when it's shattered, then psychopathology kicks in. So not secondary traumatization, but where is the potential? What do we know about the couple? About the father in the shadows or the couple in the shadows? So this is another thing, another quote from one of our participants, talking about the highly different ways of coping that she and her husband adopted after the loss. He felt relieved. He didn't understand the grief I was feeling. But then you will also find fathers saying something else, feeling that, pregnancy loss is a feminine trauma. It's an individual feminine trauma. That's how the medical institution sees it. And then, what about me? Did I get any care? Do I deserve any care? Does anyone acknowledge the fact that it also happened to me or to us? There's me and us here. So, the dyadic adjustment scale has several subscales, very interesting in themselves: consensus, cohesion, satisfaction, affectional expression, and then here you can find a variety of psychopathology, well, all the PTSD clusters and major depression. And what we saw that maybe people had good reason to study the dysphoric aspects of pregnancy loss in previous years. There is something, there is a very, very fuzzy line between PTSD and traumatic grief in this experience. And maybe that's why the larger correlations, and most of the correlations were between major depression and the dyadic aspects. So the better dyadic adjustment in various subscales was that protective in the face of major depression, and the depressive or dysphoric cluster of PTSD, which is negative alterations in mood and cognition. Okay, there is always a depressive undercurrent in this population, and this undercurrent is the one that reacts to the predictors we looked at. You can also see that when you just look at groups. This is the depression groups. And what was very interesting to see, I don't know, for me, I used the dyadic adjustment scale in a few of my studies, and I always felt that one subscale wasn't that interesting. That was the consensus one. It has a lot of, so the scale has a lot of very emotional subscales like expressiveness and items referring to conflict. But I always felt like agreement between couples, well, it's important, but it's something very technical. And in every analysis we did, and we did a lot more than those, we found that the most important aspect, the most protective aspect for couples after pregnancy loss was consensus. Whether or not they can agree on things, solve problems, seeing eye to eye, and making shared decisions without arguing. And then we kind of thought, why are we seeing consensus everywhere? This is also the PTSD differences in consensus. Why are we seeing consensus everywhere? And when we talked to some of the women, they said, at least looking from a couple's perspective, what hurts the most is the fact that you have to make a lot of decision immediately after the loss and even before the loss. So there's a lot of shared decision making. And if that's a problem, then it really hurts so much. Decision making about medical termination of pregnancy. Just imagine what happens if it hurts so much and you don't agree. There is no support. About seeing the dead-born child. There are a lot of, I don't want to be too graphical, but there are a lot of micro decisions, very, very traumatic micro decisions. Do we look at it, the child? No. you have seen the baby, but I haven't. What does that mean? Are we together in that? Because you have the image and I don't. Then decisions about burial and memorial, which today are very, very, it's a hot debate, has reached the media. Do we want to attend the burial or no, or not? Are we going to memorials? Are we trying to forget together? Or maybe we've seen couples that one is going and the other is not. How do you come home from that? Going to therapy, obviously. Having another child, and how? And more generally, coping styles. And I can also tell you from my clinic, I sometimes treat women after pregnancy loss that I see this as a major issue, the consensus. Lack of consensus or high consensus. And again, going back to the issue of comorbidity. So I myself, and I think that a lot of people in this room, have begun to think transdiagnostically in recent years. This is the era of RDocs, etc., etc. And I think that comorbidity is not just one disorder and then the other. I think that today we're looking at different psychopathological entities and different ways symptoms can cluster together. Talia can attest to that and others in this room. And what was very interesting to see, so that if you combine depression and PTSD together and then you look at the dyadic adjustment, you see that something very different happens for people who have PTSD, which are those in green, and people who do not have PTSD, which are those in blue. We try to understand what happens to those who have PTSD and severe depression, and why can we see that dyadic adjustment or support is high. We had various explanations for that. Some were positive, for example, saying that when you have a lot of distress, it mobilizes couples support or spousal support. But another one was more pessimistic, saying that we know that emotional support in PTSD is kind of tricky. And we know that for some people who are really suffering, being over-suffocated or being too supported, or they sometimes need their space. And we also looked at various measures of self-disclosure. Gadi, you talked about talking or not talking, and is that good or bad? So at least in our sample, I guess the recommendation would be, if you go through the loss and you have feelings of shame and guilt and even positive feelings, just talk to your partner. We don't know what happens to the partner, obviously, from being exposed to that, but at least some part of the woman. Talking, we assessed both disclosure specifically about the pregnancy loss and general self-disclosure about a lot of feelings, positive and negative, but they all were negatively correlated with psychopathology. And of course among themselves. Okay, I see I have like 2 or 3 minutes, so I'll try to wrap it up. But why is talking important? Well, of course, we know the immense feelings of shame and guilt and loneliness that can be alleviated by talking to the partner. We also looked at post-traumatic growth. I'm not going to say a lot about that because I see I have very little time, maybe the next lecture, but we did identify post-traumatic growth. I will tell one anecdote about that. So basically, the main measure of growth was life appreciation, and it was mostly correlated with PTSD hyperarousal. And I think, Zahava, as you found, distress does not exclude growth. Quite the contrary, it may go together for various reasons. Some of them are kind of provocative, as Yael Lahav is sitting here. She wrote about that. But I think that one important anecdote I want to say is that one of the predictors of growth, maybe the strongest predictors of growth, was how many children have you had since the loss? So remember the number of children that did not play a role. It did play a role here, but not in PTSD. And then we were interviewed to the media, and we talked about this finding, which we found very optimistic. And we got, the same day, we got like 20 phone calls from women in our sample, very, very angry, raging, saying, how could you say that having another child is a growth factor? For me, for these women, having another child was this constant testimony, a constant reminder for the loss. This was the factor for reactivation. I had already gone through therapy. I came home. I thought this was in the past, and then I gave birth to a live child, a healthy child, but this was... And it was kind of humbling to see that nothing works on averages. Okay, we know that. Okay, very general discussions. Pregnancy loss and stillbirth are major traumatic events. Are we doing enough? Zahava, you have taught us to always ask, are we doing enough? And the answer was always no. And I think that that's one of the important things of being supervised by you. We're not doing enough. We're ignoring a lot, both in terms of just I get like 5 mails a week asking me about specific protocols for treating pregnancy loss-related PTSD. Don't even try to find nothing validated. Only very good people trying to suggest things, but it's kind of weird. Can we intervene and screen early? Already at the women's department, much more attention to this topic is warranted. And again, the politics of trauma. Why are we not looking? It's an unheroic trauma. It's a feminine trauma. Women are expected to go on with their lives, and in the Israeli context, we have these sayings, right? Pregnancy is not a disease. Children are a joy, which they are. Zahava knows I always do this. How much room are we giving to this discourse in our natural stress lab, trauma empire? I don't think we're giving it enough. And even less validated intervention in terms of couples therapy, really treating the dyad, looking at it from a contextual perspective, very, very little. What is encouraging is, for me at least, that ever since this study was first published, we've been getting exposure, and a lot of very, very good and sensitive men and women throughout Israel who have been contacting us, offering their help in research, in advocacy, in funding, and it just shows the immense hunger and thirst there is for this issue. So many people who are untreated, men and women throughout Israel. We've been in the Knesset 3 times already in discussions of legislation. I think there's a very big interest, and also champions, real champions like Aliza Ravi, who is a parliament member in Israel, who actually changed, in a very short period of time, changed the laws concerning the rights of women, not men yet, but women after pregnancy loss. And a month ago, we actually established Candles of Hope, which is an interdisciplinary foundation for pregnancy loss research, treatment, and advocacy. And hopefully we'll be able to continue our research and clinical work in this field. So thank you, and thank you, Zahava.
For everyone. Please, if you could stay, if there is a specific question to the research Dani has been doing, please.
We looked at data from 9/11 among parents who lost children in 9/11, and traumatic grief was kind of came out as a different entity above and beyond PTSD and depression. And I think the opportunity here is really to understand a little bit more about the difference between trauma and loss. Obviously, losing a pregnancy or a child is really more about painful loss rather than fear for your life. And and physical integrity, and the question is really what is the underlying basis of the two phenomena and how much they interact. So the question that I have is really about whether you looked specifically for the role of kind of intrusive symptoms, so experiencing versus avoidance as predicting depression and PTSD in this sample.
First of all, I agree with you. I think that, again, what's interesting about this population is that the lines, the like kind of blurred lines between all the entities you just said. What is the painful component in their experience? Is it the loss and grief component, or something more intrusive and fearful? I think both exist from what I see. I can tell you that intrusion symptoms were the most dominant in this population, but we did not, and it's a good idea to kind of see whether or not they are the most predictive, for example, of depression and other distress measures. We can do that. That's a good idea. But they were very present. They were very present. I think that's because the event itself, and that's maybe one of the place I came from, looking at PTSD, trying to say beyond the loss and its meaning, there is also an event. The event has very sensory, graphical characteristics. Something should manifest these characteristics themselves, and I think that's intrusion. But yeah, that's a good idea. Thank you.
Thank you very much for this, and I think, and I'll be an advocate for another underrepresented population, that we really need a lot of more qualitative studies in this domain. Just the anecdote of the women calling you and saying, you got this wrong, and you're representing us wrong, it is kind of, it should be resounding in the sense that, you're encouraging them to speak to their spouses, but we as researchers should speak to our participants and learn what their experience entails and the richness of that experience. And I'm sure we will discover many things that we have never occurred to us. And I think, and you kind of presented several quotes, and I was wondering if these were also published and kind of pursued to elaborate this field.
No, they weren't, and they were not collected in that fashion. But I totally agree with you. I can tell you that this was done in between 2014 and 16, and the studies I've been conducting in other contexts since then have always included a qualitative aspect, like a built-in qualitative aspect, even if small, because I'm not a qualitative researcher per se. But I totally agree with you. I think that trauma is so multi-layered, and talking about averages and how they can mislead. And I think also Yuval's question about grief and PTSD can be enlightened by qualitative work, trying to understand that not only by looking at clusters and trying to categorize subtypes, which is very important, but how do they talk about the things? What kind of words do they use? Where is the emotional pain located? I totally agree with you. No argument.
Thank you.
Thank you.
We still.